co-instructor in this course. Disc hemorrhages, we'll start with that, are seen in about 1 in 20, that is about 5% of the eyes with various spectrums of glaucoma. But importantly is the second line here, that they are rarely found in normal eyes, and that is their importance or significance. As shown here, they are typically small, splinter or flame shape, occur at the 9th layer of the retina level, that is RNFL, and usually located inferotemporal or supratemporal. So, looking for those, look for the temporal side of the disc is the message. They are not always as obvious as in the previous slide, so sometimes they can be as subtle, hidden or masquerading behind the blood vessel and just at the border of the cup, so these require careful examination. Again, on every visit the patient comes to you, you may not see the disc hemorrhage, so they appear and disappear as seen here and not there on the next visit. But you can still make out that there was something abnormal here in the past. There is a sellout of the disc hemorrhage. The significance, these wonderful 3 glaucoma studies are telling us the significance of disc hemorrhages. The normal tension glaucoma study has shown that there is nearly a 3 times risk of glaucoma in patients who have disc hemorrhages. The EMGT or the early manifest glaucoma trial has shown that disc hemorrhages are positively associated with glaucoma progression. And the OATH study has shown that there's a much stronger association with conversion to open-angle glaucoma even when controlling for other risk factors like intraocular pressure and thin corneas. But their significance is even more in normal tension glaucoma patients. They are seen in about 1 in 5 normal tension glaucoma. The prevalence is much higher in NTG. Again, in NTG they tend to be more recurrent, seen in about 2/3 times they are recurrent in NTG, and in NTG again they tend to be scattered all over the disc and tend to be multiple. Now compare this with the other spectrums of ocular hypertension and open angle glaucoma. In those, the recurrence rate of disc hemorrhages is much less, and they usually occur at the same site at the disc, which I told you earlier is usually temporal, and they tended to be single in these type of. So there is a difference in the NTG and the other spectrums of glaucoma as regards the hemorrhages. The other significance is that they are, you can see the hemorrhage here and you can see the notch, so they are associated with the focal notch in that area. Secondly, I'll show you in the next slide, they have a localized RNFL defect that is corresponding to the hemorrhage. They have a larger beta zone as shown here and would have a corresponding opposite focal visual field defect. So all these together should really be impressive and should make us change our line of management for that patient. So you can see the localized RNFL loss. There is a hint of a disc hemorrhage here, and you can see the classical wedge-shaped RNFL defect corresponding to the hemorrhage. The mechanism, I think the 2 studies which have postulated the same thing are the Barbados and the EMGT again, and they have shown that low ocular perfusion pressure, as we know, has a big bearing in causing glaucomatous optic neuropathy. And the same lower ocular perfusion pressure has also been shown to have a mechanism or a role in disc hemorrhages also. And the mechanism postulated is that when the patient has a posture change, is standing or sitting or vice versa, then during the hyperperfusion phase, there could be a bleeding or a hemorrhage from the lamina cribrosa capillaries, which cause the disc hemorrhage. And in the hypoperfusion phase, it can cause optic nerve ischemia and the optic neuropathy. So the message is, in the mechanism, it's the blood pressure minus the IOP, which becomes your perfusion pressure. Lower it is, more the chance of glaucoma damage to the nerve and more the chance of hemorrhage. In the differential, I think we need to keep all these in mind. They could also be seen in diabetic retinopathy, hypertensive retinopathy, in a PVD, in a patient with a BRVO. Important one is the second last one. Patient could be on anticoagulants, and therefore the lamina cribrosa capillaries could bleed more easily. But how all these can be differentiated from a glaucoma disc hemorrhage is mentioned in the last line, it will have a corresponding RNFL defect. If it is a glaucomatous disc hemorrhage, you will have those either one or all the points which I mentioned in the previous slide. There could be an RNFL defect or a focal notch or a larger beta zone or a visual field effect. So those are the things to look for and differentiate from these. The influence on the management of a disc hemorrhage, like I said, it is always good to lower the target IOP when you find a disc hemorrhage. Then, especially in the NTG group, it is always good to consider diurnal IOP if we are missing a peak and a trough of the IOP. And it's been shown by a number of studies also that glaucoma surgery will reduce the disc hemorrhage frequency, suggesting that the equalizing of the perfusion pressure may have a bearing on their mechanism again. Moving on to the beta zone, these represent, you can see it first and then I'll tell you. This is the disc margin, and this white one is the beta zone, and also this one is the alpha zone. So let's look at the beta zone, which I've mentioned here represents a visible sclera. You can see the white sclera here, and underlying choroidal blood vessel vasculature can be seen. And they are associated with total loss of the RPE and the photoreceptor layer. And important is the next line, they are mostly seen in glaucoma eyes. Or let me say that again, they are usually not seen in normal eyes. And that is what the significance of beta zone is. The alpha zone, which I mentioned here or shown you here, is the patchy hyper or hypopigmentation of the RPE melanin. And you can compare the beta and the alpha, and then we move on. The importance is that, or the significance is that alpha zone can also be seen in normal eyes besides glaucoma. But again, this is a proven fact, all of us will agree to this, that in glaucomatous eyes, both beta zone and alpha zone tend to be larger compared to a normal eye. And as sir has mentioned already, sometimes these are together referred to as PPA or peripapillary atrophy. But important one is to look for that white patch next to the disc margin. The significance, as mentioned in this slide, a larger beta zone will tend to have a disc hemorrhage, and you can see the focal beta zone here, a disc hemorrhage corresponding, and this will show us visual field progression. It is often associated with a disc hemorrhage, like I said, is more in NTG again, and more with the senile sclerotic glaucoma. So the combined message from what I've shown you till today is, or till now is, that both disc hemorrhages and beta zone tend to be more with NTG, and these are subtle signs to look for in a patient who is having normal pressures. In the differential, and this is my last slide, that sometimes physiologically large cups as present here, or rarely in AION, even if the cup is enlarged. Remember, if the cup is enlarged in both these situations, there is no beta zone corresponding in AIUN or physiological cup. But in glaucoma, the beta zone or the PPA is present, like shown here. You can see a 360 degrees beta zone in this picture, and these are things to look for. Thank you very much, and have a great AIOS.